Hi, everyone, and welcome to CHSC's webinar titled Transition for Youth with Complex Neurodevelopmental Disabilities. Before we start, I do have a few housekeeping things to take care of. Good news, we are offering continuing education credits for nurses and FPSS professionals who attend this live webinar. If you're a nurse looking to receive credits for attending this webinar, please make sure to complete the evaluation survey following the session. This will allow me to keep track who is seeking credits, and your name and email will be sent to our contact at the College of Nursing. You will then receive an email with a survey that you will need to complete to receive credit for participating. You will receive 1 hour of credit for attending this live event. If you're an FPSS professional looking to receive credit through the Iowa Board of Certification, please email me following this webinar so I can get a certificate made for you. For those that need a general certificate of participation, please also email me following the webinar and I can provide that to you. More information about certification will be provided in the follow-up email. I also ask that all attendees fill out the follow-up survey at the end of the webinar for evaluation purposes. I'll be sending a follow-up email after this webinar with more detailed information regarding credits and any other questions that you may have. I also want to mention that our staff survey for the Track for Health grant closes tomorrow, so please take a few minutes to fill out the survey to assist in improving the transition process for youth with special healthcare needs. The survey link can be found in the chat box. So now that those housekeeping things are over, I'm pleased to introduce you to our speaker, Dr. Pixie Plummer. Please feel free to type in any questions that you have in the question box on the right-hand side of your screen, and I will save questions for the end and then facilitate the Q&A session. So without further ado, here's Dr. Pixie Plummer. And Dr. Plummer, if you want to share a little bit about yourself, that'd be awesome, and then you can start the presentation.
Great. Thanks, Alejandra, and thanks to everyone for having me today to present on this topic that I care very much about and very passionate about. So I guess brace yourselves for all the stuff that I'm excited to share. Really am grateful. So I'm going to talk about transition for youth with complex neurodevelopmental disabilities, and we'll kind of define what I'm talking about in a few minutes. But my background is my residency was in a combined internal medicine and pediatrics with a fellowship in neurodevelopmental disabilities. I'm currently working at the University of Iowa within the Department of Psychiatry with their intellectual disability mental illness team and at the Center for Disabilities and Development. I have no financial disclosures, and all photos in the presentation are used with consent. Just to reiterate the objectives for the presentation that went out in the announcement, we're going to identify challenges for healthcare transition for youth and young adults with complex neurodevelopmental disability, identify some strategies to involve youth in this process, and then discuss vital partnerships with caregivers in this transition process. So just a little bit about myself. I am originally from Southwest Iowa, a town called Hamburg where I graduated from high school. So my roots are in Western Iowa. I ended up going to medical school here a little over 20 years ago and ended up moving to Massachusetts for my training as part of the match and beyond. I sort of always like to share with my fellow Iowans that I spent a lot of time during training explaining that I am not from Idaho or Ohio, that I am actually from the state called Iowa, which got frustrating at times, but I'm happy to be back. I was there for about 20 years, both in the Boston area and then in Springfield, Massachusetts, in the western part of the state. But around February of 2019, I came back to work primarily with the intellectual disability and mental illness team, like I said. Now, my work and my entire career, because my background is in combined internal medicine and pediatrics, really has been, in some ways, to avoid the need for transition. I had learned through the course of my training that for many people with developmental disabilities, as they were moving through pediatrics and kind of graduating into adult care, that it often felt like you were falling off a cliff. or there really wasn't an equivalent in terms of services and supports, even just within the healthcare world, for people with developmental disabilities. So that's kind of a confession that even though transition has been a big part of my work, often I'm trying to avoid that whole disruption for people and try to keep it as seamless as possible. This, as you know, is kind of one of the primary works that outlines what the American Academy of Pediatrics considers to be standards around transition for all youth and young adults. And even though these are very general principles, I felt like it was important to put them in writing, put them on the screen to identify that there's no discrimination against people who happen to have more complex neurodevelopmental disabilities, in that we still want to have a high quality, developmentally appropriate healthcare service available in an uninterrupted manner as the person moves from adolescence to adulthood. So we still have that same goal for everyone. And this is obviously just a graphic that's part of that transition recommendation that I think I wanted to just point out for all of us again how, we really are expected to start thinking about transition as early as age 12 to 14. I think what a lot of us in the field realize is that as soon as a child is born, as soon as we're sort of embarking on the journey with them related to their health and their disability, oftentimes families and providers might be thinking about the future. So in some ways, transition planning actually may start closer to birth. But in any case, the more we can start early in terms of thoughtful planning for that transition, the better. And you all know of this, I'm sure, but just to be clear, this is the primary resource for one of the toolkits for all providers around transition. So when you get a copy of the slides, I wanted you to have access to that. So to be a little more specific about identifying kind of the patients that I work with in my practice, and some of the diagnoses that might be associated with this label of complex neurodevelopmental disabilities, this slide is just sort of a general smattering of potential medical diagnoses that someone may have as either the cause or to be associated with their disability. And you can see that it's a broad range of diagnoses. And for a lot of our patients, we actually may have something sort of general or describing, such as a unique difference in the structure of their brain, or maybe even a unique genetic difference. And that's really the only medical diagnosis that we have at this time that we think is the cause of their associated disability. Another term that I wanted to make sure you were aware of that I think is starting to be used a little more in the last few years is severe neurological impairment, sometimes abbreviated as SNI. And in the field of developmental disabilities, for those who are really focused on people often with significant neuromotor impairment, including things that might cause quadriplegia or the limited ability to move any part of the body, this term may start to be used a little more commonly. This is just a graphic from an article that you'll have access to in a link later in the talk, but it sort of sets apart SNI or severe neurological impairment as something that people with that limited neuromotor ability may also have limits in verbal communication, so that our ability to really hear from them directly is often more challenging. And I think this is another way of capturing the subset of patients that I will focus primarily on in this talk. Some of these patients with complex neurodevelopmental disability may have a list of specialists similar to this. So almost every body system may have in some way required expertise from a physician or provider trained in these particular fields. Now this is more consistent with what someone in the pediatric world would have access to, as you can see with the developmental pediatrician. And there are some of these providers that really are not as commonly available in adulthood, but this is kind of where we're starting. A patient may also have, as an example, this list of equipment that they are using on a regular basis, a daily basis, as part of their life function. And so I think you must be picturing or knowing some of the patients you support who have this kind of a profile. I often like to share this care map just to again emphasize the complexity for patients with a complex neurodevelopmental disability in terms of when you think about all the people and supports that are involved in kind of daily life and coordination of care. And this is a care map, I'm sure many of you have seen it, drawn freehand by a parent of a child with special health care needs. And this blue area is just the part about healthcare. You can see areas around therapy, legal, school, and state and legal supports are kind of have their own section. So I'll be primarily focusing on this area, but it's just another way of highlighting the complexity. So a major principle that I want to put out there for everyone is that in my mind, transition supports and effective transition really in a big way means transition to quality healthcare. So part of providing the standard of care and ensuring someone has access to the highest quality is supporting them in this transition. And one of the biggest things that we face is some actual cultural differences between kind of the world of pediatrics and the world of adult medicine. And there are some ways in which family medicine providers bridge this gap, or people who are trained in med-peds may bridge this gap. But these are just some general differences that have been commonly identified between these two worlds. So in pediatrics, a lot of the providers may sort of self-select for this practice in that they partner with people and make a plan for care that's really based on what do I need to know to give you what you need to be healthy. Where sometimes people who gravitate toward internal medicine and adult care are really the kind of people that like to solve problems, clinical problems, very focused. In pediatrics, there's more of an emphasis on growth and development over time. And that's just really not part of the training for adult providers. In pediatrics, in general, most of the patients they'd be seeing would be healthy. And so some of the patients with complex disabilities might be a small portion of their practice, whereas the whole attitude in adult medicine is often focused on illness. Communication in pediatrics often absolutely involves partnering with the parents, and that's not always the case in adult medicine. Unless they're partnering with older, aging individuals who have the support of a caregiver, they're not as used to communicating in that way. Peds is sort of culturally thought of as more nurturing, whereas in medicine, it's a little more rigid, kind of a strict partnership approach. And there's really more interdisciplinary practice in peds as opposed to just this kind of medical model that you encounter often in the adult world. Well, how does that play out for everyone really trying to access care in moving into adulthood? Some of the basic challenges for people are really around accessibility. And that includes the office building, the room, the exam table. Are patients given the opportunity to actually be weighed and measured? And are people having the time or the supports needed to get the history, actually get a full exam, meaning get out of a wheelchair, for example, for that full exam? In what ways do we have to worry about when a provider sees someone? Do they only see their disability? Do they only kind of identify or hone in on the diagnosis associated with the disability rather than kind of looking at the bigger picture? And one of the core challenges for people is to actually know that they should be expecting the standard of care, that preventive healthcare guidelines and that access to a full exam and history really are their right. It's interesting how many people sort of assume that, of course, some differences will be experienced or people will cut corners in accessing healthcare. So just having an awareness in the adult world and making sure that clinics, offices, and health systems have accessible scales and tables, even including rooms that have maybe a ceiling track for a lift to help with transfers or Hoyer lift. In terms of accessibility, part of the issue really is a challenge around knowledge. So even if someone like me who specializes in developmental disabilities was to look at kind of all the different topics, all the different specific health issues that someone with developmental disability might be facing. I mean, if you even look at what a textbook around those issues looked like, 15 years ago, 700 pages, and more recently that same revised textbook is up to 2,300 pages. And so just thinking about like the breadth of knowledge and whether or not it's fair to expect that a primary care or an adult specialist will have had access to that, it's really a challenge. Challenges around knowledge in the adult world include a lack of training or knowledge about what it's like for people who are using medical technology as part of their daily life and have been for a majority of their life so far. And this is just one example, but for someone who had a G-tube placed for safe feeding at a very early age, who has had it their entire life and moved into adulthood with a G-tube, as you transition, you may find providers have limited training or knowledge about that, and it wasn't part of their adult medicine training in any meaningful way. So often trying to encourage patients and families to be armed with that knowledge. I wanted to share with you this resource around feeding tubes, and know that often the responsibility is on caregivers to teach providers actually the nuts and bolts around changing tubes, troubleshooting like venting and avoiding aspiration, and all of these issues, whether or not their adult provider is comfortable or willing to follow up on an active problem, or even connect them to a dietitian who's experienced with tube feeding. That can be a barrier. These are some of the more common differences in terms of subspecialty culture that I've noticed in working with people transitioning to adult care. And there's obviously many other examples, but these I wanted to highlight for you. So for someone who's moving into adult neurosurgery follow-up, often the general practice really is different in that there's a decreased frequency. It's almost shifted to a more of an as-needed approach to care. And that is especially important for people who may have a ventriculoperitoneal shunt or another shunt for hydrocephalus, where they may be used to kind of at minimum a yearly follow-up with their surgeon throughout childhood. Moving to adulthood, it can be a little bit of a culture shock. Also, similarly in gastroenterology, transitioning to the adult world, there's just plain less of an interest in kind of chronic management of someone who uses a G-tube. There's less experience, training, and comfort around basic troubleshooting, like I was saying, and even issues around sort of stoma complications or wound care issues that will often be triaged to a wound care center rather than managed within GI. Orthopedics is another good example where in the adult world, even more so than in pediatrics, the subspecialty of orthopedics is very compartmentalized by joint. And so when you think about moving from pediatric orthopedics because of your cerebral palsy or quadriplegia because of your spinal muscular atrophy, often it's hard to find an equivalent in the adult world who really is thinking of you as a whole person and trying to figure out what you need, both for comfort and function. Neurology similarly, kind of an as-needed approach to care. And sometimes if you have been on seizure medications without dosing changes for years and years, they'll even sort of shift you back to management by your primary care provider. And that can be a little bit unsettling for patients and caregivers just who are not used to that approach. Just to put also on your radar, I think that more and more we are seeing our patients with complex neurodevelopmental disabilities connected to the specialty of pediatric palliative care. That's really been growing in the last decade, and it may not be available in all health systems across Iowa, but it's definitely a big part of support for people with complex needs here at the university. The equivalent or sort of corresponding adult palliative care practice is so much more geared toward people facing terminal illness such as cancer that it's often difficult to kind of make that transition over to their subspecialty follow-up. And I'll talk a little bit more about that in a few minutes. So many of these patients that we're talking today as having complex neurodevelopmental disability, in the medical world, they are labeled with terms such as this. And they'll be scattered within the chart, or as people are communicating about them, these are the kinds of labels we may see. They may have been called medically fragile, having complex needs, being technologically dependent, or that SNI term that I was talking about. A subset of these patients actually have such significant challenges in terms of their disability that actually may be difficult for a provider to perceive any voluntary purposeful movement. And that plays out in a way where they are dependent for all transfer or mobility, either rolling from side to side or shifting from bed to chair or back again. And these patients are almost universally unable to perform self-care on their own. So they really are dependent on the caregivers who are with them for all activities of daily living. One of the effects of some of the attitudes in medicine in general is that historically, our patients with disability might actually be described in the chart with terms like this, neurologically devastated, wheelchair bound, or actually an adjective like unfortunate, or sort of assumed to be suffering from all of their medical diagnoses. On another front, they may be kind of constantly referred to as stable, which for many of the families that I work with or caregivers, that can be actually a little annoying to them to always read, because they can tell the medical providers sort of assume them to be always just living on the edge, or it doesn't always really capture all of the work and all of the interventions that are required every day to achieve that stability. It's just a little too simplifying. Well, how does this play out in terms of transition and just really thinking about attitudes and that attitude as a potential barrier or challenge for transition? One of my mentors who taught me a lot about attitudes was Dr. Alan Crocker in my fellowship at Boston Children's. And he actually use the term exceptionality in working with patients with significant or complex neurodevelopmental disability, and help explain what that may mean in the following way. It's really reflecting about the personal features or the individual features of patients with profound disabilities, and thinking about what do medical providers see as the basic elements of a person's humanness or personhood. And in a lot of ways, for patients with this level of complex developmental disability, the way we get to know them is by listening to the people who love them. Their caregivers almost tell us what they think that they're thinking. Um, Signals or clues that they pick up on about whether they're happy or sad, or think that you're doing a good job or that you're being annoying. Um, Ways in which caregivers and circles of support are able to pick up on an expression of individuality. Signs that someone is responsive to what they're doing, and also paints a picture of someone's social place. And one of the more profound ways in which that may play out is, moving through the course of their life. For those who do pass away, like in what ways are we learning how they are missed? Um, just painting a picture again of them as a full person. I thought, especially with my desire for neurodevelopmental disabilities training and being very committed to working with patients with disabilities, I really thought I was ahead of the game in terms of acknowledging these things. But I just wanted to admit to you and tell you a story that kind of, as you go through your medical training, when you evaluate a patient, you often end up taking all the facts and interpreting them and regurgitating them to your teammates, or even in a way such as this. So I evaluated the 6-year-old girl named Linda, I remember. And when I was reporting to the team, I described her as having spastic quadriplegic cerebral palsy, seizure disorder, feeding dysfunction, chronic respiratory disease, status post G-tube placement at 16 months for failure to thrive, a trach at 3 in the setting of hospitalization for adenovirus pneumonia, and with status epilepticus. I gave my ideas for what should be done for her and recommendations for additional services and treatments. And we finished our conference and moved on for the day. And I'll just always remember Dr. Crocker asked if he could talk to me afterwards. And he said, Pixie, great job. You really covered all the important points. But can you do me a favor? The next time you present, can you, instead of talking about a diagnosis and a function, can you talk about a person and a life? And I was actually crushed because I didn't realize in all the ways I had sort of taken this girl and turned her into a list of her diagnoses. But the bottom line is that really is, in a lot of ways, what the medical world does. And it's just even much more pronounced for people with developmental disability, and even more so when all of those complexities are kind of transitioned into the adult world. So one of our challenges that makes the biggest difference is our efforts to continually paint a picture of a person and their life to any healthcare provider that they come in contact with. So very rapid fire, take you through one of the more challenging situations that I was involved in, where even despite all the best efforts, you can find yourself, feels like swimming against very strong currents. So in 2008, I remember being contacted and basically asked for help for a 31-year-old man with Cornelia de Lange syndrome, who had transitioned to the adult world in all ways, all of his providers, but he was really struggling. Part of his clinical picture did include quadripresis, dysphagia, so he needed a G-tube for feeding, and intellectual disability. Over the course of his early adult years, he had really struggled with pulling out his own G-tube repeatedly. And every time this was going on, the adult providers just kept putting in a bigger tube. And by the time I met him, he basically had a chronic leaking G-tube site with this essentially a non-healing fistula. Because of that, you couldn't give him any G-tube feeding over 30 cc's an hour, so an ounce an hour, without having it leak. And at the time I was meeting him, he had basically been told by a surgeon and multiple providers that there really was no treatment that was available, and that they didn't think that because of his level of malnutrition, so this is a 31-year-old who weighed 42 pounds, that he would necessarily even survive a surgery. They basically met together and decided as a team that hospice was his only option. And I was coming into this very late to the game, but there was no way I was going to disrupt kind of that shared decision making. But I was kind of getting to know, like, okay, this is the complex situation we're dealing with. At that time, the team put the focus on comfort, pain control, and initiating hospice with these low, slow feeds. And I sort of worked on maybe shifting the calorie content and just really monitoring his comfort level. But as you can see, 6 months later, JS was absolutely still alive and really actually showing no signs of worsening condition. And in fact, with a lot of love and attention from his group home, he seemed a lot stronger despite his low weight. So we met again and we decided maybe we should actually seek a second opinion on this. And we ended up seeking care in a subspecialty center in a bigger city, connected him to adult GI and surgical specialists who actually scheduled a plan to revise that G-tube. The OR was booked and he was ready for pre-op and procedure. And when he went to have his assessment, the anesthesia department of this referral center had to cancel the surgery because they said, we don't have the right size equipment. We can't do anything for him. And all of us were just shocked that that was even an acceptable situation to be in. So we basically, even at his age, were given like a last chance scenario of re-engaging with pediatrics to beg for help. They agreed to see him as an outpatient, and in that visit took one look at the situation and immediately admitted him. They actually had to give him TPN for close to 3 weeks just to get him strong enough to be able to have the surgery. And by the time they went in there, they realized that that whole time he had actually had a giant bezoar or collection of like foreign body material that was preventing his successful feeding, that the people on the adult side had not looked at or found, and removed that, revised his G-tube site, and set him up with a whole new plan of feeding. You know, 2 years into this journey after that surgery, he went to a rehab and he had sat up for the first time on his own, actually getting proper nutrition. And, you know, I continued to follow him, and even 8 years after all of that drama, he had actually gained enough weight that he was starting to become overweight, and we were having to look a little bit at diet control. But so even with someone like me, and with all the best efforts, these are the kinds of things that people worry about. It's like our worst nightmares that we all have to be prepared for. So here are some helpful strategies. A lot of this is really practical advice that I hope is helpful to you, but also that you feel comfortable sharing with families and patients. But one of the goals of our talk today was really, in what ways can we still involve youth and young adults in this process of transition when they have complex neurodevelopmental disability? And I put to you that a lot of it goes back to that sharing of their individuality, either ways they can share on their own or ways that their caregivers help us understand. So really painting a picture of their personhood, their social place in their family and their community. And how can we think outside of the box about what communication and sharing can be? And I'll show you some examples. But again, emphasizing the power of this to change attitudes and to improve care. It actually can be the key to successful transition more than people may realize. So in the process of caring for patients and coaching them about what they need to share, their providers should have answers to these key questions. When I am well, what is my personality? What are my favorite things to do for fun? What gets on my nerves? I want to know favorite TV, movie, music, activities, things I'm good at. I want to know who favorite people are in the world. This is part of getting to know the person, and any way we can get that information into their chart is helpful. Um, Even patients that we think of, we may meet them for the first time at 16 or 17. We think of them as nonverbal. I always remember there are patients like Ruth Sinkowitz Mercer, who actually was in an institution for a majority of her life. It wasn't until she was in her 40s was able to write her own autobiography after someone really discovered that she could use augmentative communication. And this is a woman that left an institution, again, in her 30s, and her autobiography included photos of her out in the community, but using even very basic augmentative strategies that were available in the 80s for her to be able to even write her story. The powerful part of that is she often actually could think back to moments when caregivers assumed she didn't understand what they were saying, or assumed that she was enjoying what they were doing when really she actually did find them annoying. So my confession is I've often kind of a little wary that at any moment I could be annoying to my patients who can't tell me. So sometimes just kind of checking in or looking for clues at all times. But as you know, we have patients who really may need to use augmentative strategies, even really basic ones in the course of their visits. Some can actually use tools to share about themselves ahead of time or complete a form such as this to either use at the time of a visit or to prepare for future visits. I'll let you review those later. But these are the kinds of things that we can encourage people to document, like what's the best way to communicate? What should people know about hearing and vision? How do we know when something is bothering or hurting? And during a time of illness, how do you know something is different? So again, practical strategies, here's my inside scoop. When it comes to transition, as far as general recommendations, I tell patients and families, don't wait to ask their providers, all of them, directly about timing of transition. And that really means just saying, do you have an age limit, or is there an age when your office is usually planning on having me move to an adult provider? Both providers and caregivers sometimes avoid this conversation because there's a lot of guilt or fear around it. So it gets put off, and I just would coach people, go ahead and ask. It's better to know. Try not to transition everyone all at the same time. There really is no need. And one example is that often people are partnering very closely with a particular subspecialist. Maybe actually a lot of what they've been battling is around safe feeding and breathing, recurrent pneumonias, or other chronic management of a certain body system issue. Sometimes it's smart to go ahead and transition your primary and keep that subspecialist until you've kind of set up your home base in adult primary care, and then can shift to the subspecialist at a later time. Okay. Another thing is really be prepared for the unexpected statement from an office staff or scheduler. And part of why I share this is that many patients or families are actually somewhat traumatized in that moment where they call to schedule a follow-up, and someone, not the provider usually, will suddenly say, oh, they're 21, it's time for them to move on. I can't tell you how many times that it's actually been like that moment of calling to schedule that a family hears that for the first time, and it's really traumatic. So I try to give them the heads up just so that they don't have to worry, and they can be prepared to say, no, actually, we've had a conversation, or I'd like to clarify that with my provider first. Some general recommendations about identifying a primary care, which actually can be one of the bigger challenges. and happy to talk about that more with anyone later. But some of the more important issues have less to do with their specific knowledge around disability and more really thinking about other sort of aspects of care, like location, whether actually another member of the family gets their care with this provider, and where are they integrated in the health system that subspecialists are a part of. And any experience working with older adults is actually a plus because there's some crossover in strategies for supports. When you're getting ready for office visits, I try to let people know that some of the really basic access of care considerations are the most important in terms of feeling comfortable during that transition. So really thinking about parking and building entry, and that alone can actually affect choices around where you would want to go. The more you can kind of take control of the registration or check-in process, like if you need to not be waiting in a waiting room, it is okay to advocate and explain, this is what I need in order to enter the building and get ready for the appointment. That first appointment with a new provider, I try to encourage people to schedule that when they're well and feel absolutely free to overshare as much as possible, either spoken or in writing, about what works best for communication and the physical. Providers need to know that from you. If you can take an approach, especially in those first visits, of not feeling like, oh, this is make or break it. So if you feel like the personality match or the way the office works is not a good fit, just kind of take a deep breath and realize, okay, well, we'll see how this works. If it's not a good fit, then we'll try somewhere else. Sometimes it feels like the stakes are so high, it puts a lot of pressure on the whole situation. Another tip that I share is that often first impressions with a provider who's meeting you or your loved one with disability for the first time can be deceiving. So if they're nervous about doing a good job, they can look like they're standoffish or intimidated or afraid. But I can't tell you how many times that it's that second or third visit when something clicks and they are realized that, okay, this is a partnership and this will work. Here's an example of a potential way of putting information in writing in a portable medical summary. This format is available on that Gone Transition website, and it's a PDF form that's editable, so you can personalize it. I wanted you to know this exists. And here's just some other examples of portable medical summaries that I do encourage people to create, either something that can be shared virtually or uploaded into the chart, whatever works for you. Some people even put it as a PDF on their cell phone to share. This is an individual whose caregiver and grandmother actually came to visits with a set of photographs. So any new visit during the process of transition, she carried 5 photos in a manila envelope with her. And she made sure to include photos that gave a sense of his room and all the equipment, storage that was needed to care for him. But on the front of this envelope, she also wrote about him and handed it to the provider. And I will just read rapid fire for you. You know, this last paragraph, because of the care he gets, the coordination among his caregivers, he is healthy, even if challenged. He doesn't know of the life he could have had. He only knows every day is a good thing and that there are lots of people that care about him. That's a life worth living. And for her, all of what she wrote, but also that last paragraph, felt really important and felt like that was her best chance at making an impact for quality care. Some specific advice around access to specialists. I am meeting a lot of patients who don't know about the specialty of physical medicine and rehab, otherwise called physiatry. And that ends up being a great option for long-term follow-up of people with complex neuromotor disability and orthopedic and spasticity management needs. I try to let them know that as far as neurosurgery follow-up, you may be responsible for kind of advocating that you do need to have a shunt evaluated, and that unfortunately, I've been in situations where it's really our job to help convince people on the adult side, this is an issue, please help us. You've got to think about the shunt when there's a clinical change. Another area that I let people know about is sometimes as you're moving into adult procedure realm around GI issues, there's a clear partnership between GI and interventional radiology. And just to have people know that that is more of the strategy for adults often is that interventional radiology is in charge of a lot of the tube replacements in many hospital systems. In terms of strategies for the emergency room, again, bring that portable summary, and if at all possible, include a photo. Those end up being worth 1,000 words in terms of emphasizing when someone is well, and also letting them know, like, when this symptom occurs, it usually means this could be a problem. Be ready. During transition, you may suddenly find out they're shifting you to a different part of an ER if they happen to have a pediatric and an adult side. It may be our responsibility kind of to explain to people when I'm actually sick, because sometimes people will assume someone with complex developmental disability is sick just at first glance, looking at their complexity. And this last point really is powerful. A lot of times patients and families actually don't want to be admitted that they need a couple of things taken care of, and they realize they're actually better off at home. And it is okay to kind of be strong and stand up and let the providers know, you know, I actually don't need to be admitted. They often know more than healthcare providers at this point, at this stage of the game. Other very basic strategies around hospital admission. The more you can let people know exactly what you need, and sometimes this can be in the form of written material, but I've even had patients actually create pages with pictures that they actually hang on the wall of their hospital room, so that as shifts change, nurses can all see, like, whether it is a technique for position changing or hygiene cares, or even specifics around catheterization needs. The more you can just go ahead and share what you know about works well, the better. And that is difficult for people sometimes moving from the pediatric to the adult realm, where it does feel like you're constantly having to teach people what you need. But the more comfort you get around doing that, you'll see that people actually do want to learn and they want to do it right. They just might be intimidated to ask. I always let people know that, especially if you're in a hospital that has both pediatric and adult care specialists, it really is okay for them to call pediatric specialists and ask for advice, or involve them in your care, especially if you're seeing they're having some trouble or understanding or managing a particular issue. Keep that summary with you. Like I said, the photos make a difference even later in the admission. Write down names of people that have been helpful. Befriend that discharge planner, and then just kind of be mentally prepared to hear anything, whether it's a statement that's off base or actually sort of a brand new plan of care that you weren't prepared for. Just the more people can be prepared, that sometimes a lot of things might catch you off guard that first admission to an adult side, the better. Actually can be beneficial for my patients with developmental disabilities to be on a teaching service. I've seen that they often take an interest and are really open and willing to learn. Again, you can request consultation from providers you trust. I would request to be a part of the rounds. And always remember there's a nurse manager on any floor that you're admitted to. Um, Again, be specific about what you need when it comes to special procedures. Um, and just to skip to the bottom point, just don't be daunted by a one-size-fits-all approach. You often have to just be proactive, talk to the manager of the department, and let them know, oh, this is actually what I need, which is going to be a little different than the typical patient that you serve. So this patient of mine actually, anytime he came to the hospital, when he was sick, he looked horrible. He looked as if he was on death's door, and his family always said that. And people often made a judgment that, oh, well, things are tough. This may be the last, for him. And often he would turn it around. But it wasn't really until they pulled up a picture of him smiling during admission when no one was around and showed it on rounds that the whole team sort of realized, oh, that's Corey. Oh, that's what he's like when he's well. And it totally affected their approach to his inpatient care. Um, One of the biggest challenges for my patients entering the adult world is that they often are immediately asked at every interaction, first things, first, what is their goal of care or code status? And it can really catch people off guard when you're used to working through pediatrics with a relationship with the provider. And if they have not brought up some of these conversations, it can be very off-putting and even feel threatening when a provider that you've never met starts asking about code status and whether you want to resuscitate or intubate. And so the more we can bring this up sooner, the better, and think of it more as advanced care planning and goals of care. Wanted you to know about this book, which I think is a very powerful sort of testimonials for patients and parents who have basically spent a whole lifetime constantly protecting their child while in the hospital, and always afraid that there were maybe ways in which they weren't considered to have lives worth living. That can kind of create an attitude where you're always a little fearful that you have to protect people from talking about these goals of care. Um, I really recommend that every single family and a provider who works with people with complex neurodevelopmental disabilities have this book. And this physician, who is a palliative care and complex care specialist, wrote it. It's the most authoritative, practical, useful guide to lifespan care, actually, for people with complex developmental disabilities. And she also takes special attention and is an expert around thinking about pain and comfort. And you should know of this particular article as a great resource. The sooner the better for our patients, both in pediatrics moving to adulthood, that we set a standard for asking about pain and assessing pain. It's a huge help moving into the adult world. So know of these tools for people who don't use words or who can't speak, especially if they're acutely ill, about signs of pain. And these are just some examples of ways in which someone may show pain without words. The more we can know about them, the better. I wanted you to know about these two resources that really look at an approach to lifespan care, but thinking about our goals and what we want out of life and what it means in terms of daily life and medical care to share both with families and also those adult providers. But, one huge lesson that I guess I've learned all these years from parents, caregivers, and when possible, patients themselves, is that in the process of transition, before they care how much their provider knows, they often just need to know how much they care. And I have found the more providers see the real person, the know of the real person, the more they're able to access that approach, that caring approach, and really focus on quality moving forward. But thanks for listening. I'm sorry that I took so much time. Um,
No, thank you. That was awesome. Please, if you have any questions, please ask them in the question box, or you can also raise your hand and I can unmute you if you wanted to ask your question with your speaker on or your mic on. But Dr. Plummer, that was great. I love how you shared very specific questions that, we can ask the parents, and um, a lot of these transferable skills that I think that would be really useful in our clinics.
I also am absolutely open to direct emails from anyone within CHSC.
Let's see here. Um, I had a question for you. So what types of resources do you find are typically missing or hard to come by when providers are trying to educate caregivers about how to transition their young adult with, medical complexities or, neurodevelopmental disabilities? The reason I ask this is because we're currently reviewing our CHSC's transition resources, and we realize that a lot of them just assume that at 18 or 21, a youth is going to be mostly independent, and that's not going to be the case for every child. So I was wondering, what kind of things do you find are missing in like your toolkit um, or stuff like that?
And let me make sure I understand. So do you mean the toolkit, like, for instance, like a GOT transition toolkit or
Hmm.
something like that?
Yeah.
Um, I think the way that I approach care for people with complex disabilities in all ways is that, and includes in transition, is that it is actually helpful to imagine and to learn from what the broader group of people who are transitioning, what do they want and what would their goals be? And then for a person with a unique complex disability, um, actually try to translate that, still holding on to in what ways can this person show me to the best of their ability what they want from life. Um,
Hmm.
the other way that I actually take all of these toolkits, these very broad based toolkits, and I either modify them, in my own mind, or I just absolutely put like individual slash caregiver into the mix so that I would use the same tool, but it might be a group effort. So that whether it's in a conversation about what can I do, or whether it's a conversation about what do I need, I basically just broaden the circle of who is sharing. Um, that way I don't have to sort of reinvent tools for each person. I find that too overwhelming. I don't know if that answers the question that you meant.
No, it does. Thank you. Another question that we had was, with Iowa being a rural state, what are some challenges that you're seeing um, versus like your previous experience in Massachusetts, for example, when it comes to transitioning this population?
Well, I've only been here 2 years. I'm originally, like I said, from a very rural part of the state. But I've actually found that I'm meeting a lot of families who maybe haven't accessed what are, what I would consider almost like national standards or guidelines around a certain diagnosis. Um, and so they may not actually have this expectation for a certain standard of care. And one really basic example might be around cerebral palsy care. So, a provider doesn't know what they don't know. A caregiver may not know what we don't know. It's sort of up to us to kind of let them know, oh, this is actually the standard practice for people, whether it is access to a certain type of treatment or therapy or follow-up. And so I think the more we can share patient and family-based resources. So for example, actually connect people to like their Cornelia de Lange Syndrome Family Foundation, connect people to the Cerebral Palsy Foundation. encourage people to connect with families either virtually or in those groups, because we're not all able to go to the big meetings, and we may not all be able to go to clinics where there's the so-called world expert in any given condition. But almost all of us can get online and learn from each other. So I think there's a lot we could do more in that area.
That's great. Thank you. Um, so I want to be cognizant of everyone's time. So we're going to end there, but thank you again for taking the time to develop the presentation, share with us, and I know that this will be so useful to our staff moving forward. For staff, please make sure to fill out the survey that's in the chat box, and then I will also be sending up a follow-up email with information about credits as well as this slide deck, and I'll also put that on our CHSC shared drive. So thank you. Have a great rest of your day.
Thanks, everyone.